So to kick off, we want to talk today a little bit about technology and our providers and how it impacts the provider's life. So we know that over the years, provider burden has led to burnout. We have a pandemic now of burnt out providers. So what are some things we can do as organizations to help temper that burnout that we're experiencing?
Well, I think Jen and I have been working with our company to launch a quality documentation class that includes kind of three buckets, and one is kind of resetting just what is quality documentation, is the standard. Another is looking at prediction health AI chart auditing abilities to sort of see where are they at. And then I think the third is probably answers your question a little bit more, which is we've been able to start using ambient scribing to help them with their documentation.
Yeah, I think specifically around the burnout side of it, physical therapists are just high achievers in general. And it feels like when you're plinth side, that the payers just keep changing the rules. And it's really hard to try to reconcile that while still delivering great patient care. And so the part that is really interesting about the delivery of all of this is that one would think that the documentation standards would be really boring and no one would engage with it, but everybody's hungry to know what the expectations are. Mm-hmm. And as standardized as we can make them to stay within what's being required for compliance or something like that, everyone's craving it. So I think, there's always going to be 80% that we can try to standardize. And then we need technology to really support us on the outliers. Mm-hmm. So just to go back to the burnout piece, I mean, PTs are trying to do it the right way. They just don't even necessarily know at this point how to do it the right way. And so we need the technologies to support them. But then we also need to be really clear and give them what they can do first pass and be successful that way.
So if we unpack this a little bit, we have documentation burden is kind of where we've settled. We know on one level we can take some of that away with an ambient scribing sort of model. We'll set that aside for a second because I think there's a lot to unpack there. But as an organization, you've said we can help providers do it right. How do we think our documentation is playing out in the world right now? Do we think they're doing it right? Do we think they're doing too much? Do we think we're doing some of the right and some of unnecessary and some of not right? It seems like there's lots of ways. And you said people are craving it. What is it? What is this that what's the needle we're trying to thread?
I mean, I think there is all of those across the organization. There's people that are, squarely in the over documentation camp. They need help writing less. We've got under-documenters too. We've got some people that are doing well on one type of note or one portion of the note, but not on others. And so I think that's where technology can support us with that.
Speak a little more to that. So how do you, in that lane where we've got this swath of people over versus under and some in the middle, how can technology help us to deal with that?
So the prediction health chart audit scoring can help break down by note type, but as also by like the different sections of the note and looking at, their scoring rubric kind of looks at CMS's documentation guidelines as well as APTA's defensible documentation, what should be in your note. And so it's telling you whether you're doing a good job on each section of the note, and it gives you what you're doing well, what you could improve on, where you're over documenting, where you're under documenting. So people can make really focused changes to their documentation. And I think that's been well received. Like Jen said, I think when people hear the topic documentation, they're kind of like, oh, but actually as we teach it, it's so engaging. They want to do well and they have lots of questions, and nobody wants to get a poor score for the most part. Like people want to do well, but they don't. It's balancing that, like, all the patient visits they have at the end of the day, managing their care team, and what do I need to put in the note?
Yeah.
I think that's the question that keeps coming up. And I can remember even 5, 10 years ago, when you're writing your note and then you have your neighbor peer review 10 of your charts, right? That's 10 charts. It's riddled with human error. It's got just so many questions. And so to truly make a meaningful change in my habits for documentation, I didn't trust it. Thank you for the feedback, but I'm not going to do anything different because no one has proven to me that it's actually going to achieve something different downstream. I think now when we have this many data points, we have a sensitive tool that's going to tell us yes, no, it really does give us a chance to make some informed decisions. And that feels different. And I think that's why we've been able to get people truly engaged with it, because all of the pieces, when put together, feel like a portfolio that you can trust.
So it sounds like one of the things technology can do is use retrospective review, a way that only a machine learning based model beyond what we can do with our human bias could do, to look at our body of work and then give us some focused insights. It seems like you're over documenting, seems like you're under documenting, seems like in this area you're having a problem, but in this area, so it helps us to be more focused. But now let's speak a little bit to, so you have the insight, that's great, and the technology can give us, or give somebody the insight. What you've done, and maybe we unpack that a little bit, is a little more than that. How do we get from the dashboard says something to some administrator that may or may not look at it, to now we have a cohesive implementation plan that actually changes these habits based on what you're learning? Seems like that's more than a technology problem.
Yeah, I think the most important part that we've stressed is that in all of this is people-centered, this is quality-centered, it is not punitive. Because that fear piece has to be removed in order for habit to truly change. So we've been really forthright. I almost feel like it's a sandwich conversation. Like at the beginning, we say it, and then we get into the details, and people are starting to probably get a little bit anxious. Like, oh, my score is not, like, that's a scary number. And I have a lot of things I need to do. And then we come back behind it. We're here. We're going to support you through this. So there does have to be a very intentional implementation of it, because I think immediately, again, you have high achievers. So when you give them an area where they're struggling, they're immediately going to get nervous. That's uncomfortable. And again, it's new information. So that feels raw.
It's been interesting just to see now that we've had this tool for several months and have quite a few people that have had, more than a month or two into it. Like a lot of people with the lower scores are bouncing up at least 10 points, so knowledge is power. People do want to do better. I think they just didn't know before.
Yeah. And now you speak to so the audience understands, we've rolled this out. This is not just ambient scribing. This is not just the insights dashboard. So these folks have improved. Maybe if you can describe a little bit about how you rolled it out and what it is exactly you rolled out. But then what in that you think is responsible for this increase that you're seeing?
So the actual session, we require everyone to be not in person, but live on Teams, Zoom, or something like that. Because we want to make sure it's engaging. Just watching a recording, it's very easy to step away. So we did that very specifically. And then Val talked quickly about the 3 parts, but we open with this. These are the expectations. This is what has to be there. This is how you do it on our documentation platform. So that's where it starts. And it really I think it lowers everybody's, if they were anxious, they're not anxious anymore. It's very familiar, but it's very clean and clear. And then we go into looking at their data. So knowing what you know now, what does this look like and how are you scoring? And then this is how technology can start working better for you by releasing all of the scribing things. But we're making sure that they know exactly the functionality. And I think because it's so stepwise, it's fast and we move quickly, but it's stepwise and it builds on itself to where they walk away going, this really feels like technology is going to assist me, not be an additional burden and add to the weight of all of it.
Yeah. I mean, just to add clarification, we are giving them the insight to their data, and we're giving them Sidekick, the ambient scribing tool, all at once. So there is that to consider when you look at, okay, a month or two later, their charting score has improved. They are being given a tool that will assist them too, but they also have that knowledge of and that review of like, oh yeah, this is what should be in mine.
Well, and it feels like full
Documentation.
transparency,
Yeah.
right? I have everything that I need to do. If I put myself plinth side, okay, I'm going to make this change, and I know where I can measure it and see if it's moving the needle next month. That feels pretty good to me, right? That feels like a whole package, because initially we thought we would just roll the scribing piece out by itself. And Val was the one who said, whoa, wait a minute, this needs to be a package. And it's worked beautifully.
So we've kind of labeled it quality, but also efficiency too. Like, can we achieve both? Because usually those things are not going together, right? So
You, Val, said we were just going to roll out an ambient scribing tool. There's a lot of sentiment in the industry right now that we just have to do that, and you take the burden off, and that's what everyone's complaining about. So let's just roll that out. That's actually the biggest problem. You seem to push back on that. Why? And in your approach, how does that?
well, I think I just felt like I didn't want to give them this shiny new thing, like Jen's always saying. Like they need to step back and think about like, what is in my note? What belongs in my note? What does quality look like? We haven't reviewed with our therapists in a long time, like what documentation should look like. And it's really one of those topics that that probably most people need to hear bits of it every year. Like you just need it sprinkled here and there, because people work in silos in their little clinic, and you get into habits and you see your neighbor doing the same thing, and it starts to feel like this is permissible, when actually there's a standard we should uphold ourselves to, and it's there for a reason, and that's what quality looks like. So I just really felt like they should be packaged together. Like quality and efficiency in this case can go together, and it's been fun to see it sold that way. And I appreciate all the efforts that went into that by lots of people on the team to make it, because it would have been much easier to just hand out the technology of ambient scribing.
Well, and I think we're not just talking about their audit score. We're not
Yeah.
just saying, and your subjective looks pretty good, but your assessment really stinks. We're also talking about pajama time. We're saying,
Yeah.
hey, you might have a great note, but if you're doing it on Saturday night, we need to talk about that part too. So that's the people piece. And we could talk about quality all day from a, are we getting it done? Then ultimately, are we getting paid? All of that. But if it's at the sacrifice of the therapist, then all of a sudden, that person removes themselves from the equation. And I think that the balance is the piece that we also have been trying to strike, saying, you can write a great note, but you need to write it while you're in the clinic, just because that's what you need for balance.
Yeah. So let's pivot a little bit. I think this idea of quality and efficiency can go hand in hand. But if we have quality over here, we've got operational performance over here, we've got financial performance over here. It seems like I've been a PT almost 25 years, and it seems like we keep piling these things on, and but it's only one more thing. 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 As an organization, how have we gotten here? We know we've got maybe potentially a technology solution as a part of the way out, but we're going to keep adding things over here. How have we gotten here so far out of whack with fill in the blank thing we're requiring with efficiency getting so unbalanced?
I have a lot of opinions on that. I think kind of back up one step. I think Val and I do a really good job of putting ourselves in the position of being plinth side and doing the work and feeling that burden, right? I think that's the best word for it. It's just heavy and it's a lot, and it feels like one more thing, right? So I don't know that I know the answer to that, other than if we can all step back and we can say, well, what is standardized? I mean, when you think about care delivery and then how much time we spend documenting, that's the majority of your day, right? And we talk about clinical care all the time. We talk about getting better. We talk about the new interventions or something like that. But like Val said, we've gone many years without, we're improving our documentation platform, but we're not saying, hey, because that payer has changed dramatically, now this is all shifting. We're just adding templates, or we're trying to maximize what the platform can do in terms of, I don't know, format, right? So I think we all have to be disciplined enough to step back and say, okay, what are the common things? Like really think about how the burden can be thinned out a little bit, because it's in response to payer change. You said it.
Yep. Yeah. Ultimately, it's the elephant in the room. But yeah, an EMR system. What's an EMR system? An EMR system actually is a revenue cycle billing system. Yeah. All of them. That's what Epic was. It now is an EMR, practice management. But at our core, we're trying to get paid. So it is what it is.
Yeah. Sorry, I was trying not to say it out loud, but that's what we're responding to, right? It's not necessarily that it's helping deliver better patient care, because our therapists are doing that. We have a team that helps them do that. But actually writing it all down is payer-based.
Yeah.
Yeah, I mean, I agree. I think how we got there is, the shift in things in the last decade or so. But I think it's good to step back and think about, like, how do we support our providers in creating, a good patient experience, a high quality documentation that will serve the business well too.
And on the flip side of that, now we're talking about this first pass idea, which I think is fascinating, because oftentimes that first pass, so if a note or an episode of care gets kicked back, we always think, oh, that the back office will handle that. Well, ultimately that hits the provider again, and it's quite disruptive. I mean, the communication back, if it's more than once, it is disrupting the flow for what they're trying to achieve at the moment. So if we can now get our hands around how to have a higher first pass rate, because the notes are complete, because it's met payer regulation, all of those different pieces, because the technology is working really well, I think that's going to be fascinating. Because our providers then are going to be able to focus on the patient right in front of them, not the 5 emails that came from the back office, who are there to support them, but ultimately it is disruptive.
Yeah, I think this is the key. So I'm an informaticist in addition to a PT, and in my research world, one thing we find in the technology space is the best done technology takes a remedial standardizable task and helps with that, take that off our plate. So now you're left free to do the things that aren't standardizable. So I think one of the things you guys are helping to do is to identify these are things that could be standardizable. When you define those, then technology can be applied to those and we take them off your plate. When I think most providers, and I think by extension probably most clinic directors and maybe even owners of businesses, can't do that. So they can't say, okay, wow, there's a real problem here. What of this is a process problem? What of this is an actually training problem that our folks just don't understand? What of this is a I don't care problem and we have a cultural issue? What of this is a conflict between I'm asking this and I'm asking this, and actually they're at odds with one another? So it seems to me what you're doing is helping to segregate those and then applying technology appropriately.
Yeah, and quality is so nebulous, right? I mean, when you say ops is super easy. I mean, it's lined out and man, so easy to understand with metrics and conversation. And what you just said is the quality piece, and that's what makes it hard, because immediately we start doing concentric circles, right? And they have so many different factors that are putting forces on, but then it's hard to measure. And so immediately it gets bumped out of the conversation because it's hard to get our hands around it.
Yeah.
So I guess let's pivot once again. We might come back to this. So we talk of quality. I spent a whole academic career focusing on how do you even define it and to your point. We define in essence what it is, but pragmatically we can't. But one thing that we would all agree with in the documentation world is note accuracy. We can at least say, if what you put in your note is accurately reflecting what you said and what you did with the patient, that would be one measure of note quality. So you also said earlier in the manual reviews you've done, your partner does 10 of your charts and you do 10 of her charts, that there's a lot of bias and you don't trust it. It seems that there's trust in this, well, AI did it and ChatGPT is amazing and it can really take a ton of knowledge. So there's trust in that system. Is there risk in having this blind trust in the system right now?
Absolutely. I think those are the conversations that we have on a regular basis is we have a bit of a luxury right now because it's the fresh new thing and everyone's digesting that. And then we are anticipating probably in the next data reset that we get that we're going to start getting well, I changed this and it doesn't feel like a very sensitive tool to me, right? And challenging the algorithm and challenging how we respond to it. So this is a story that will keep writing itself because I do expect that there's going to be pushback, and the blind trust is short-lived if the tool isn't doing what we think it's going to. How we respond is a whole nother.
Yeah, I think some people will have that blind trust, and it's our job to help protect them from that and make sure that, like with the ambient scribing, that they really understand you have to authenticate what it writes. Like, it's a tool to use, but it is your job to make sure that what you put into that chart note is true and represents what happened in the visit and represents your clinical reasoning. And that's a huge responsibility to not take lightly when you hand somebody over this technology.
And part of our research prior to ambient scribing even being a thing was on human scribing in medicine. And we saw the same problem, and it's no different now.
Yeah.
So my question is going to be, how as an organization can we deal with this? We saw many physician providers, our research team looks at physicians, who would blindly authenticate, especially when you have a scribe that you have trust, that you train and you trust them. Then we would go back and actually do quality audits and say, ooh, there's a lot of stuff missing. Ambient scribing, we see the same thing. So we don't have a solution now, but we're going to have to at least have a framework to go towards. What can an organization do to help increase the gravity of this? Because I think what we found in our research was most folks signed it off because they're like, it's mostly right and it's good enough, and I'm already burdened, and so I'm not going to spend more time doing this because I have this great tool that makes my life easier. I don't want to add another layer of burden to my life to make it less great. But the answer we found in human scribing was the organization held them accountable to note quality. How do we do that as an organization?
Yeah, I think you just said the word. It's the accountability piece and it's measuring. I mean, we now have visibility of who is copying entire sections of what's coming across in scribing. And again, this isn't to go knocking on someone's door and the quality police show up, but it's to say, are you truly reviewing that? Do you feel like everything? Just asking the good question. So I think that'll be our first pass at it, to say, okay, we're seeing that this percentage of providers are looking like, it appears that they are just taking everything over and not making any changes, not deleting something, engaging with the proposed text. After that, I don't know what it would look like.
I think the other side of the coin is that Prediction Health has been a really great provider or partner to work with, and so we have providers who are reaching out to Jen and I saying, like, this text doesn't represent, or this text is outside the scope of my license. It's saying that, we had one come in last week about like the patient should go get a cortisone shot if this doesn't work. And it's like, oh, we got to work with Prediction Health on like because that's not what the provider said. How do we tweak that verbiage that stays within our scope? So I think on the other side of that, Jen, we've got to hit this from two directions. We got to make sure that, like you said, that we're addressing the providers who are blindly trusting it, but we also have to make sure that we're working with our partner to improve the technology side of it as well, so that they are we're giving them feedback on what is not right, or what's a hallucination, or what's just worded in a way that doesn't fit within the scope of what we do.
Yeah. So basically holding our vendor, in this case, Prediction Health, one, accountable, but two, being a collaborative partner with them to make the product better.
Yeah, they need feedback to improve the AI, right? Yeah.
I think as you guys are talking, I'm thinking about something being static versus stable. And our providers don't want change. I mean, there's change fatigue, right? So I think that there's that. But they also want to know that the tool is developing this. I mean, we've been saying you can help train the AI by doing this, this, or this. So they feel like this is not a static tool, and that we have a vendor that is receptive to feedback and needs for change. And they are. So all of that is true. But it's going to be on the team that's backing this to make sure that that continues, because I think that's a set expectation on the provider side now. Like, we have made it very clear that that's all happening. If we suddenly are like, oh, new project, that's going to feel incredibly, I don't know, like we lost our allegiance, you know, we're not doing what we said we were going to.
Yeah, I think that one thing to bring up here is whatever solution is brought to us is not perfect. It's good enough to achieve some of the aims. Right now, at least, efficiency seems to be the big itch that's scratching. Quality, probably, and at least our anecdotal evidence early on is saying yes. But we know that these tools aren't perfect. So yeah, you have to give feedback. One scary point we have, emerging research we haven't published yet, but we've taken a look at 5 different AI companies in the medicine world. Prediction Health was not one of those. 5 different companies, fed them the multiple encounters, the same recorded encounter with a patient and a provider. And then we looked at how much the different models between the different vendors agreed. About 10% agreement. There was about 10% total disagreement. And then in the middle was a mix of some agreement, some not. So even from vendor to vendor, accuracy is not there. And then we have to also ask ourselves, what's the biggest risk right now? Is it this error of omission, so that you said something but the AI model didn't pick it up? That's actually the most common thing. So we do need to really look for, and it's the hardest one, because you forgot, you moved on, and is it actually there? We don't know. But commission is also there. You use the concept of hallucinations. This is something most people don't think about. AI is only based on probabilities. What it heard and what it thought it heard and what it actually heard are 2 different things. And then it has to use probability to apply a framework to that. And it can get it terribly wrong. And so I think the commission ones are easier because you'll see it and be like, oh, that's weird, if we read it. But the omission ones are probably going to be the bigger problem going forward. And again, the models don't even line up. So we have to work with the vendors to make them better.
Yeah. Todd Gifford called it the space race. And it's totally what it feels like, that everybody's trying to roll something out and be on top and get that, first in type thing. And I think that lends itself to what you just described, right? And some people will blindly say, and we have now implemented, and we go. And I don't believe that that's the right answer. It has to go through iterations.
Yeah, and that's why I'm so impressed with how you guys are taking this process through for therapeutic associates, because at the end of the day, a company has to be clear on why they're doing something. And I believe right now the biggest burden we have is we have burnt out workforce. Documentation is the biggest contributor to burnout in providers. We know this empirically. So if I can just make it less burdensome, then that's my focus. And that's a very altruistic aim, and that's great. What you have done is to say, yes, and our quality needs to be there, and quality needs to be defined and collaboratively agreed upon between the vendor and the organization. And that takes work and focus from an organization. And then there are other elements of quality that we also have to look at. And then provider, hey, you've got a part. We're going to make your life better, but we're going to make you focus on the things that are important. And where you started is make this the important thing, so they see what's important and what's not. I've given a bit of a monologue, but if you can speak to that, you've actually touched on multiple areas that I don't believe most organizations are recognizing as necessary, because there's this big one of documentation burden. That's the easy itch to scratch right now.
Well, I think we pumped the brakes multiple times, and that probably wasn't super popular because everyone was trying to get to that one piece. For me, it's having been the provider, and I decided to take the role of skeptic. And I think by just sitting and continually pushing and poking and trying to say, okay, then what question could we ask then? Slowed it down just a little bit. But I think it got us to the point that we knew we needed to cover those buckets. But my miss was that I thought it would be just scribing. And that was where Val balanced that out and said, hold on, it would actually behoove us for all of these reasons. And that made a ton of sense. So the thoughtful pause, maybe, is why.
I think two things, like Jen said, like really thinking about the provider experience in this too, and the product that we're creating, and not just taking away some of the burden of documentation. I think the other thing we haven't talked about is we spent a lot of time working with Prediction Health to validate. We didn't let people have the tools or see the chart AI data until we felt like it was where it needed to be. Like that, that was almost 2 years, right? Like, we didn't just take, one of the 5, like you're saying, and say, oh, it's done. We've worked with them for a long, long time to say, this is what we feel good about for outpatient PT, right?
Yeah, I remember vividly rolling this out early to you specifically, Val. We had the insights. We said, this is the model. We had a few people, and one of our best documenters in the org, he said,
well, that's
you were great, but you have a heart for it. I would say realistically, you're one of our best documenters. And when we showed you the score, said, help me and graciously help me to understand how this is true. But I bet internally you're like, that's not true at all. And ultimately, I think this is the problem with technology. Black box of technology. We have no idea what's happening behind the curtains. If we throw you out something that just simply makes no sense, we should question it. You were gracious and now turned it into a very positive for the organization. If we don't do that well for our providers, we lose them before we get out of the gate because they simply don't trust. And once you've lost trust, you've lost everything. So to wrap up here, thank you for your time first. It's been great to talk with you about what you've done at Therapeutic Associates and how technology has helped that. If we do lightning round, you get 30 seconds. What's the next thing that you'd like to solve for? Something that we could do that you think is most impactful that would remove some other element of provider burden?
Well, I think we've talked about the chart scores, and we expect most people are going to kind of self-correct into an acceptable range. But I think the next step would be to have a quality mentor that can help those that need more help than just seeing their score, that need workflows or need a deeper understanding or whatever it is that the reasons are that they're not hitting the mark, that we support them with that.
Yeah, and mine would be more around the specific nuances of payers. I would love to see technology capturing that better so that our, whether it's admin staff or clinical staff, are trying to remember all of those little rules for specific entities. And I would love for technology to capture that somehow for us.
I'd add for mine is operationally defined quality. So we know that it's wide. You've said we can't define it, but an org can. At least this is how we're defining quality. So we can define that. Our people are asking for it. They're demanding to be measured on these things that we know we should be doing. How do we operationally define something that's important to them and ultimately use technology to both refine and remind? Great. Well, thank you both for your time. This has been immensely valuable. And again, like I said, I'm so impressed with what you guys have done with taking technology, but making it part of a bigger socio-technical engagement. It's a people and teams at the end of the day. That's what we're helping, and technology is only a piece. So thanks for all you're doing.